Good afternoon, everyone. Welcome to the Association of Baltimore Area Grantmakers for the impact of the federal funding cliff on community health centers. I'm Elizabeth Harlick, the Programs and Initiatives Director here at ABAG, and we're pleased to have you all here in person and also to welcome people from across the country via our webcast. I also want to thank Blue Cross Blue Shield for sponsoring this session, meaning the technology and our lunch. So I do want to note we are recording the program. We've had some requests to be able to share it afterwards. So that will be available if you let one of the ABAG staff know that you're interested in having that recording, we can get it to you. And then for those of you on the remote participation, Donalyn is monitoring that, and so if you have, so the lines will be muted, but if you have something to convey, please use the chat feature and do so that way. All right, so I think that's about it with housekeeping. So I'm going to invite up Hosanna Asfami from Care First to make some remarks.
Hello, everyone. My name is Hosanna Asfami. I'm the Grant Program Manager at Care First Blue Cross Blue Shield. Thank you for everyone here in the room and also remotely for joining us. Today we have Jason Patnash, Alex Harris, and Kevin Lindemood representing different organizations. Jason and Alex representing the National Association from the Community Health Centers, and Kevin Lindemood representing the Healthcare for the Homeless here in Baltimore.
Muted.
Yep.
So, NAC was founded in 1971, a few years after the overall community health center movement itself, which is now about 53 years old. Mission is to provide the provision of high-quality, comprehensive, and affordable health care, coordinated, culturally and linguistic competent, and community-directed for all medically underserved populations. So something many of your foundations are very familiar with. You probably see one health center, you see one health center, as the saying goes. There are 1,400 FQHC, federally qualified health center grantees overall, and I'll go through those essential elements that give them that designation. That's about 10,400 delivery sites nationwide. So traditional buildings that you might know, primary care center, also homeless health centers, like Kevin, school-based clinics, and agricultural worker sites. In addition, public housing health centers. So all fall under the Section 330 of the Public Health Service Act for this designation. When you look at NAC as a whole, we are the national voice for the community health centers. Alex will talk a lot about the advocacy aspects and the kind of policies that are impacting health centers today. But to give you a full picture on NAC, we have the traditional membership and meeting roles that we play. We have probably of the 1,400 health centers, probably about 65% are actual members of the association. Yet a lot of the work that we do and training that we provide is available to all. NAC has a large cooperative agreement from HRSA to provide training and PA on an array of different operational items for community health centers, regardless of membership inside NAC. We're also the convener of 20 other cooperative agreements from HRSA that provide additional technical assistance to health centers. And a lot of this cooperative technical assistance helps to strengthen the health center operations and the populations that they work with, looks at their workforce issues, looks at their health information technology issues. And so by doing that, NAC is spread across several divisions that include training and technical assistance that is respective of our state partners, being primary care associations and health center control networks. Also a large clinical affairs division, which has partnerships with the CDC that I'll go into a little bit further. Making up the rest of the organization, outside of that traditional administrative roles that we have at the organization, and a large public policy division made up of our federal affairs team, state affairs, regulatory affairs, research, and advocacy communications. Next slide. So what is an FQHC? Where does that designation come in? And I'm sure many have seen some of these words thrown into grant proposals at times. They're familiar with some of the language, but I want to really dwell on these for a little bit. So they are located in high need areas. That need could be based on a lack of providers in the area. It could also be a lack of culturally competent providers. It might be providers who don't speak a certain language for the population they're serving. It could be the access to primary care. You could find two health centers that might even be near similar areas, geographic areas, but serve two very distinct populations. And so especially in urban environments, that's something that you would expect to see. Kevin will be able to talk about his health center and their uniqueness of serving the homeless population in Baltimore, where he's probably not as working as much in dealing populations that go to Chase Practice, for example, or Baltimore Health Services. So you can see an array of different health centers serving populations. The health center has to provide comprehensive health and related services, and especially enabling services. A lot of what we have been calling enabling services for years, but now the term is social determinants of health. And so something you're probably very familiar with. And so a lot of our health centers have provided these services for decades now, access to housing, linking patients with food programs, checking in on the safety and wellness of elder seniors or homebound seniors, so things that health centers have been doing for years. We're now tracking it different ways too, and have a lot of initiatives that actually help to support the social determinants of health at the health center level to show that when a health center gets a patient, this patient's likely coming in a little sicker, a little more in need than somebody going to a primary care doctor, for their normal visit. And so that really comes into a lot of play when you're talking about reimbursement to health centers, health insurance payments for health centers, and why that they have this higher level of these patients. The health centers must be open to all residents, regardless of their ability to pay, with a sliding scale fee charge based on income. So health centers will sit down with the patients when they come in, see if they are eligible for any programs. Health centers have been leading in the ACA enrollment efforts throughout the years, have taken hits with the O&E outreach and enrollment cuts that have happened, but have still just moved on, progressed forward with it. And even the report I see this morning is that the enrollment numbers are actually up. The first week, so that's actually really figuring the barriers that now have space. I'm going to skip number 4 and come back to it, but the health centers follow performance and accountability requirements requiring their administrative, clinical, and financial operations. You guys are stewards of a lot of resources for health centers. They also report to the federal government on their grants. These are well-run organizations that have a lot of different requirements they have to report on. There's a lot of different opposite partners. They also report a lot of data. The Uniform Data Source system that they report is unlike any other real data that you can really get in the country when it comes down to working with populations. So knowing your health centers are doing a lot of data collection are opportunities to build off that information they already do without asking them to do efforts or to think of new workarounds for something they're getting to a lot of that patient data. So I want to come back to number 4 because I think it's the feather in our cap as a movement. This is the largest and only community-run healthcare system, primary healthcare system in the country. The boards of the health centers have to be a 51% majority are users of those health centers. A lot of health centers exceed those numbers at times, and a lot of you, in some cases, may even at times suggest board members to join the health center board. That's something that I think is a real opportunity for where funders and other partners could be involved is whether it's serving as members of the health center, and you have your own conflicts of interest, I know that has to be general, but also recommending other folks to join the health center, other partners. That's what they really need help with at times, is that board development and that governance support, and in addition, also working with their, the board members that already exist on their board level training. Those are the kind of things that really help strengthen organizations. Excuse me, next slide. So how is NAP leading the health centers into the future? With 26 million people uninsured, NAP provides several different ways to really work with health centers. We convene at our national conferences, 2 large conferences annually, Policy and Issues, in March, and in August, our annual convention. We bring in over 2,500 to 3,000 health center staff, advocates, board members to those conferences every year with an array of different education sessions and offerings. Have worked with outside presenters at those. Great opportunity to also highlight work that foundations do at those with their local health centers. We have a whole research poster competition that we do at our August conference, and that's a great opportunity to really help spread some of the great new work that you're doing. We train and provide technical assistance to health center staff and boards via online learning, webinars, and other resources. This is everything from essentially how do you turn on the lights at your health center and get that grant moving to much more involved lately on mapping out your emergency preparedness plan. It's something very relevant in several states that we're working with now. We coordinate and participate in research-based advocacy for health centers that Alex will talk a little bit more about. We intermediate for membership and support strong health center operations. I with this division, partnership and resource development, actually work as an intermediary between funders, both at the corporate level and at the private level, who want to look to NAC saying, can you work with an array of health centers on a specific initiative? I'll go through, a couple of examples on that on the next couple of pages. I'm going to skip over the next slide around the communications infrastructure, but just briefly on that, I've mentioned the conferences and some of the other meetings that we have. We also put letters, blogs, magazines, committees of our board, table reports. So there's a lot of opportunities where we try to highlight what's working in the field and what's working for health centers. It's a great opportunity to really tell those stories, because when you see what's working, a lot of health centers, what I talk to partners all the time about is health centers love to go swimming. None of them love to jump in the pool first. They always want to see who's doing it first. They want to learn from each other, and they build off that. And while as much as they also love learning collaborative, and they are in many, they also reach points of fatigue on those learning collaboratives. And so they love to teach and then pass on for somebody else to also take opportunities. So with 1,400 potential CHCs across the country, there's a lot that do raise their hand saying, we're good now, but have you talked to so-and-so over here? It's a great opportunity to engage with a larger network. So how does that partner? This is everything from working with universities, like A.T. Still University out of Arizona. We helped to set up a dental and medical school that actually does on-the-ground curriculum in the classroom for about 1.5 years of the dental and medical students, and then places them at 10 campuses across the country where they can learn on-site with the health center. We work with several different corporate entities on product donation, medical donations, chronic care programs, grant programs that we serve as a pass-through for those, several foundations, the federal government, a lot of work recently and over the last decade, I should say, with Direct Relief. They're a national relief organization responding to medical disasters. So September was extremely busy for them. They're responding to every single hurricane in addition to the earthquakes in Mexico, and have been on the ground in Texas and Florida and Puerto Rico still today. So there's been a lot of roles that they've played, and NAC works closely with them. Next slide. Several of the foundations, that we work with, you can see from a national level. But also I do want to highlight, the kinds of community benefit in the Blue Shield Foundation of California, because this is a state level effort where NAC has been involved, and we work with our partners in California to deliver some of the products directly on the ground, deliver some of the resources and deliverables. So it's something where NAC does not play that lead role in trying to organize over a national collaborative, but we work more with our state partners on the ground and partners to bring in expertise to help strengthen the local effort. And so it's been really valuable in that project. We've done that in a couple other places also in an area where the association is starting to work more closely. And I think that's a value to the field, working with what is known as the primary care associations in each state, which are state versions of NAC, and they would say that NAC is a national version of them. But they do a lot of the efforts that we do, but really have that more of that focus on the ground. So navigating partnerships, this is work that we do with our field, whether it's health centers or primary care associations. You can imagine when the ACA passed and a health center fund was set up, the calls for everybody to work with health centers was happening, whether it was for the first time or for long-term supporters. And we had to do a lot of triaging. We had to say when it was, good work and when it was maybe you're just selling for a moment. That was a lot of corporate partners. I think a lot of insurers have also started to figure out the best ways to work with health centers. And so definitely, to our friends in the room, Blue Cross leaders who have been in this kind of space for years, like, Kai UK, those have been ones that have been at the table and on the ground with health centers even before, and so they've been these strong partners. But it's been helpful to work with our state entities to really see, well, what is a partnership like? And as many of you know from under level, it takes two to tango. We try to see, is the partnership productive for NAC and the health centers and PCAs? We look to see if it's aligned with any of our core organizational priorities, and also for the funder, is it aligned with theirs? We avoid mission creep as much as possible. And we encourage our health centers to do the same. We encourage them not to get involved in projects that aren't advancing their mission. It begins from the state and local levels a lot of times, and they'll come to us and we work with them and give them insights and training and advice on how to approach. And then also we talk to them about sustainability. We know that dollars, whether it's federal, private, corporate, whatever it is, it's not always going to be balanced. There's going to be questions on sustainability. And so how do we encourage the strengthening of the organizations as they look at that? And then finally, how can they measure success? So the speak that you provide for them and those resources that you provide them we're training on those same things. We're really encouraging them to look at their work that they do and not necessarily chase every dollar, that's there. To be responsible about the projects that they're on, because their success is going to depend on those next dollars and next partners that could be down the line for them. So I think the reputation of health centers and the strength of health centers is why we're, in an interesting spot today with this health center funding cliff. They've been seen as a strong primary care leader and responsive to the needs of the underserved, and then we're here today all of a sudden with the program of threats, similar to CHIP, similar to other things that have been working. So I'm going to turn it over to my colleague Alex, who is going to knock home much more because this is her specialty, this area.
Thank you guys for being here and for your interest in this topic. Before I dive in, how many of you guys are familiar with this cliff issue? Okay, a little bit. So I'm going to start mostly from the basics, and I always start with this graph because I'm a pretty visual person. But this is what health center funding looks like from the national level. Our national funding totals about, you can see there, about $5.1 billion. And it's seen incredible growth in the past few years. Originally, the health center program was funded on an annual basis through discretionary funding through Congress. We still get a large part of our funding through that process, and our advocacy efforts are really, really fierce every time the budget proposals are being put together. But as you can see, those light gray bars, it's kind of hard to differentiate. That started in 2011 came through the Affordable Care Act, so there was a large investment put into health centers through that piece of legislation, which really massively grew the health center program, massively grew our reach and the patients that we serve. And it went up over time, but of course it wasn't written into law past 5 years. So in fiscal year 2016, a couple years ago, we faced a really tricky situation where our funding, that piece that came from the Affordable Care Act, what we call our mandatory funding through Congress, was going to go away, and we were going to be left with, at a maximum, that dark gray discretionary funding that we advocate for every year. That results in about a 70% drop in funding nationwide, which is pretty catastrophic for a lot of our health centers. Obviously, each health center is incredibly different. It would impact them in a very different way, and Kevin can speak a little bit to the local impact. But we've got a lot of health centers that are struggling, are in pretty rural environments, are seeing really fierce competition. And so that would have been a really terrible situation. So we had massive advocacy efforts for over 1.5 years, and I'm really glad to say we were able to extend that funding at its current level for 2 years. That was through the piece of macro legislation that went through SGR Medicare DocFix. So we were part of a pretty large health care package, must-pass bill that got huge bipartisan support, and it was nice to sort of hear the members of Congress on the Hill speaking at health centers as a really big benefit of that piece of legislation, which of course had to go through anyway. But of course we're left here 2 years later with the same scenario where funding is, actually technically we've already passed the cliff. Our funding has gone down by about 70% nationally, and Congress has yet to implement a fix to this. So we can go on to the next slide. So this is kind of, this is what I like to show our advocates because it kind of puts it into context a little bit. That pie graph is maybe a couple years old, but it was the average nationally health center revenue. And so it's going to be, again, very different for every individual health center, but on average, the health centers receive about 21% of their revenue directly from the federal government grant. Their 330 funding. And that 70% of that piece would go away. So when I say 70% cut, a lot of times people are like, oh my gosh, that's crazy. But it is 70% of that piece, so I would like to make that clarifier. But that is huge. As you can see, the numbers on the right are actually estimates from HRSA, from HHS, in terms of the impact nationally of that loss of funding over time. That's talking about 9 million patients losing access to care, 51,000 jobs lost, and 2,800 out of 10,000 sites closed nationally, which is massive. It's a massive loss, and of course that's the direct impact, right? All the indirect economic implications of this, in particular for smaller communities where health centers are one of the largest employers, is really huge. So it's something we're definitely working really hard to avoid, and you can see why it's a big part of our policy agenda right now. We had a lot of discussions back a couple months ago when Congress passed their three-month funding continuing resolution about whether or not that fixed the cliff, and we had to do a lot of sort of Q&A response to that, but no, unfortunately, it did not fix our funding cliff. What it did is it helped extend that dark gray bar, that discretionary funding we received, for the additional 3 months that they passed it. But it did not fix our cliff. This is mandatory funding. Technically, it occurred at the end of fiscal year 2017, which is the end of September. So we're past the quote-unquote deadline. And then, of course, we're in the boat with about 20 plus other programs that need extending right now. You guys probably know that CHIP is in the same boat. The National Health Service Corps and the Teaching Health Center program, which are two workforce programs health centers rely on heavily to help recruit and retain providers. Maternal child health funding, special diabetes funding, dish payments for hospitals, and the list goes on. So we are one of the higher price tags of these programs, but we're certainly in good company. Not in a great situation, but in good company. So we've been working really closely with a lot of our partners on trying to advocate for a package to extend some of this stuff. So what have we done so far? There's been a lot of stuff, and I'm really, really proud of somebody working grassroots advocacy of our folks at health centers that have been working really hard to get the message through to Congress about how important this is and how urgent it is. So we recently had a success. Last week, the Champion Act, which is HR 3922, passed in the House, and this act actually extended health center, National Health Service Corps, health center, and CHIP funding to providers too. It passed in the House. It was largely passed along party lines, largely, because some of the ways that they proposed to pay for these programs was through the Public Health Prevention Fund and some other things that Democrats took issues with the Public Health Prevention Fund, probably the biggest. And so that has to go to the Senate, of course, for something to pass the Senate. It needs 60 votes. That's going to be tricky if something is so divisive along party lines. So we're targeting all of our advocacy efforts right now on the Senate to make sure that they come to a bipartisan agreement about what the fix looks like. But the good news is we have a lot of support that we've been able to document in a few different ways. One is we have two separate bills in both the House and the Senate where we've been able to get a large number of co-sponsors. Those bills are largely sort of more sort of markers instead of things that we actually think are going to go through, but they do extend health center funding for 5 years, so it kind of puts on the record that a lot of members of Congress are really supportive of a long-term extension. We have also had several sign-on letters in the Senate, for example. We had 70 members sign on in 3 days to a Senate letter. That was an exhausting 3 days, but it went really well. And so that shows that there's a huge level of support. We've also been really asking members of Congress to show publicly their support for health center funding and really put pressure on their colleagues. We've had a ton of different media outlets for statements, tweets, letters of support, et cetera, that have come through. Not quite come to fruition yet, but at least we've got the support there. Go to the next slide. So this is kind of my go-to advocacy alert. I know you guys have different situations about how you can advocate in your professional capacity, but if some of your personal phones on you and you want to take that out and go ahead and take action right now, I would be highly supportive of it. I don't think you're rude. So we have an action center. It's hcadvocacy.org, and I should have written that up there, but hcadvocacy.org is our advocacy hub. Advocates can put in their address. It connects them to their members of Congress. It pre-populates an email, a tweet, and a Facebook post that they can send really easily. Personalize if they like, do it as many times as they want. We've also got a hotline number, a toll-free number folks can call to be connected to their members of Congress with a pretty simple script. We have action pages and alerts in Spanish and English. We have what we call the Washington Update, which is a policy newsletter. We also have like what we call patient-friendly communications that are a little bit simpler and less policy wonky. that request folks to take action to show support for their communities. So we have a lot of different tools and resources for folks to kind of mobilize in their areas. This is just kind of our current alert. And I'd be remiss if I didn't say this is just one of our many issues we do track and follow and advocate for at NAC. Some of the other things that are really core to health centers are first and foremost probably the Medicaid program. So we've been doing a ton of advocacy over the summer and the fall through some of the curriculum replace conversation. We also are very closely involved in conversations about 340B program, as well as different workforce programs. Obviously, health service corps, teaching, health security, kind of at the top of the list right now. We're doing a lot of work on substance abuse and the opioid epidemic, emergency preparedness, public health funding, and then also immigration is something we've been tracking really closely and providing some technical assistance and answering questions for our members. But that's kind of my spiel, but I'm happy to answer any questions.
And I'll add one other point of, to Alex's great presentation, two points. One is, are any of you working with rural health centers in the room or primarily? Okay, so yes, some in rural. So, one interesting thing is the telehealth work that rural health centers are doing and the telecommunications efforts through the FCC grants and resources that they get. That money from that fund is overextended, essentially, is that there's more people asking for it from across the country than there are dollars available. And this is an FCC level decision that they can change. They don't need acts of Congress to change at the FCC level. So if you look on your own phone bill and see that little USAC payment, that's the fund I'm talking about. So this is a big issue actually impacting a lot of rural health centers that came onto our horizon over the last, I'd probably say 6 months. And then everything that Alice just went through and that I went through and the scared, what we're scared about with Medicaid also and why that 40% of Medicaid payments, we see how in flux that is in right now also. Now I'm going to take that and apply it all to the island of Puerto Rico and the Virgin Islands and just say 10 times more on everything we just said. But we are responsive to them. Right now I should be able to say also close to 95% of the health centers in Puerto Rico are actually up and operating on a regular basis. Some are still through generator power, but they were responsive on day one, so they were really on the ground. I know some in the room have, called and asked about other partnerships that they have with, folks that are supported in Puerto Rico. And so they're doing really a lot of work, and programs like Direct Relief and AmeriCares that we have worked with have been on the ground since day one. So the health centers and PCA in that state are really doing a bang-up job. The Virgin Islands has been without power since Irma, even, and they have also been open. The health center had to provide supplies to the hospital, actually, and so there's amazing stories really coming out of there that, it's definitely on the overall, I think, philanthropic world to make sure those stories stay in the people's view, because this is going to be a long-term rebuilding in both those spots. So I just wanted to put those in there, two other things that we're following. Yeah. I'll pass on to Kevin, who I think is provide the expert on the ground local, perspective.
I don't know about experts, but I will on the ground. Hosanna, I was with Jeff Burrell this morning at the GBC, and he was talking about very much what we're talking about, the uncertainty of the healthcare environment. And I think we all left that discussion rather depressed. And now I come here and we're talking about the funding cliff, which can also lead one to be rather depressed. I'm going to attempt to strike a little more of an optimistic tone. Great. About all of this. Healthcare for the homeless itself is, as Jason mentioned, one of 4 special needs community health centers, all part of the consolidated health center account. Healthcare for the homeless, migrant and community farm workers, school-based clinics and health centers in public housing. But our origins, when we began, is very much an example of the power of the philanthropic community, particularly the foundation community, to create more lasting change. Late 70s and early 80s, contemporary homelessness reemerges on the landscape at levels not seen since the Great Depression. And communities all over the country are scratching their heads and trying to figure out why. There was a physician by the name of Phil Brickner in New York City who was working out of St. Vincent's Hospital and had established, he had had a career of going out and working with low-income people in housing, but started noticing that there were more and more people coming into the emergency room, literally with everything that they owned on their backs. And began asking, why is this happening? What's going on? It was a vice president from the Robert Wood Johnson Foundation who was visiting New York, saw someone literally lying on the sidewalk. Today, we would think that that is a common everyday occurrence. At the time, it was somewhat alarming, and he was matched up with Dr. Philip Rickner. And out of that conversation, the Robert Wood Johnson Foundation and the Pew Charitable Trust launched a nationwide research demonstration project to try to understand what the emerging health needs were of this population. 19 cities were funded. About 45 of them submitted applications in 1984. 19 were funded in 1985. Healthcare for the Homeless in Baltimore was one of them, operating out of very modest gigs in 2 Catholic charities shelters, one for men and one for women. We had a nurse practitioner in each site, an off-site administrator. It was about 5 people, seeing about 700 different people the first year, about 1,700 patient visits. That program went on nationally for 3 years, and that's the conclusion of it. Homelessness makes you sick. If you're already sick, it exacerbates existing illnesses. You're likely to get sicker, and it really complicates treatment and access to care. Mainstream health systems, it was generally acknowledged, weren't fully meeting the needs of this population that couldn't pay, largely didn't have insurance, couldn't even navigate sliding fee scales in many cases. And in 1987, the federal government, in its first response to homelessness, something called the Stewart v. McKinney Act, created in law, created the National Health Care for the Homeless program, modeled upon the experience of those 19 centers. So today, there are just shy of 300, about 295 healthcare for the homeless programs operating all across the country. About 50% of them are in existing federally qualified health centers, an additional program of those health centers. About 25% of them are freestanding independent nonprofit organizations like Healthcare for the Homeless here in Baltimore, and about 25% of them are based either in hospitals or in public health departments. So Seattle King County, for example, is a wonderful program that's based in the health department, and they coordinate staff that work throughout the shelter system to provide healthcare for the homeless services. So just to echo what was already said, if you've seen one health center, if you've seen one healthcare for the homeless program, you've seen one healthcare for the homeless program. Those 295 clinics saw 934,000 different people last year. Community health centers in total reported serving 1.2 million people experiencing homelessness last year, and that is probably an undercount. That's individuals that were actually identified as experiencing homelessness. We began growing in Baltimore, as many of you know, working with many people in this room, by making our services much more comprehensive along the lines of what Jason and Alex were just talking about, both the required services that health centers must provide and the services that vulnerable people need in order to actually move off the street. So adding more comprehensive mental health services and addiction treatment and outreach services, adding dental care. I'll bring us up to 2013 because there's something really significant happened then. In 2013, we were operating in about 2 sites. We had about 125 staff members, about a $13 million budget. seeing about 6,000 different people a year. Then something happened that we were talking about called the Affordable Care Act. And in 2013, about 70% of our clients were completely uninsured. So when we grew as an organization, we grew by approaching many of you and saying, hey, we have a need. Can you help us fill it? We grew by applying for public sector grants. We were largely a grant-based organization because only 20% of our clients had Medicaid and 10% had Medicare. And the rest, that 70%, were uninsured. January 3rd, I'll use that date because that was the Monday. And that's the date that sits in my head because we went from 70% uninsured, so 30% insured, to 90% insured. Right. Largely because of how the state of Maryland, one of the originally states to announce its intention right away to expand Medicaid, the way they did pre-enrollment of an old so-called indigent care program into Medicaid, exceptionally well done. They don't get enough credit for how well the state of Maryland navigated that transition. They would say to us, it's going to be like flipping a switch. People will be insured, and we said, yeah, we've heard that before. It never happens that way. It actually happened that way, and I don't want to say that there weren't administrative snags along the way. There always are with any system, but in general, most of our clients were uninsured. The very next month, most of our clients were insured. And that has continued to fuel the growth of the organization, along with increased investment in grants. The $11 billion was in the Affordable Care Act in investing in community health centers so that there was more places for people who would now have insurance to actually be seen, right? We thought rather dichotomously, as we were kind of stepping back a couple of years before Medicaid expansion and saying to ourselves, okay, we've been a grant-funded organization. What's going to happen? We're going to have to bill. We're going to be more of an organization that relies on billing. What's going to happen to grants? Well, billing is going to go up and grants are going to go down. That's what we hypothesized. We were completely wrong on that front. Why were we wrong? Well, the $11 billion in health center investments is part of it. Also, all of you that we would approach to subsidize our physicians, and you were all very smart and would say, okay, healthcare for the homeless, what is your sustainability plan? We didn't really have much of a sustainability plan. Foundations and individuals and corporations still had money to invest. That didn't change and go away. It could be invested in different ways. Right? So, okay, you don't need us to subsidize your doctors. What do you need us for? And so that allowed for more collaborations to meet the more comprehensive needs of the patient population that we're serving. So what we saw is that, yes, grant billing opportunities went up, but grant opportunities went up too, at almost the same trajectory. Today, a $26 million organization, so doubled from 2013 financially, 270 staff. Last year, we saw more than 10,000 people, 111,000 patient visits, on pace to serve more this year. Our budget picture is about, I appreciated this analysis here, our budget picture for billing revenue, Medicaid and Medicare, is about 40% total. About 40% is public sector grants, federal, state, and local, and that final 20% is a combination of other sources and foundation, corporation, individual, philanthropic support. I often shudder, and I'm sure you do too, when we hear in response to an opioid epidemic, oh, the community health centers will take care of that need. Or when we hear about cutting back investments in Medicaid. Oh, but don't forget, we have community health centers in our community. I think that probably collectively makes us have a seizure. Community health centers, organizations like Healthcare for the Homeless, need and depend upon three primary sources of revenue in order to stitch together the comprehensive services that our patient populations need. And that's whether that's Healthcare for the Homeless or Chase Braxton or Baltimore Medical System or any other community health center. Medicaid doesn't pay for everything. The public sector health center grants do not pay for everything. Private support doesn't pay for everything, but when you leverage all three of those together, you can have a financial model that works to deliver care to very vulnerable populations. When you take away any leg in that three-legged stool, you experience trouble. You need to either cut back comprehensiveness of services, you need to cut back the number of locations that you're able to go, cut back the number of people that you're serving. The sites that we are, how are we doing on time? The sites that we are going to now, fueled by this growth, our main operation that many of you have seen at 421 Fallsway. We also have a clinic in some decommissioned hospital space of Bon Secours on the west side, a larger facility that just opened on the campus of MedStar Franklin Square in Baltimore County, a standalone dental program at Our Daily Bread, the city's largest soup kitchen, a convalescent or respite care program at the city's largest shelter, a mobile clinic that goes to about 8 different locations in greater Baltimore, mostly Baltimore City and Baltimore County, and then outreach-based services, providers that visit multiple, about 16 additional locations, shelters and soup kitchens on a regular basis. Some of the themes that we've been experiencing because of this growth, and that other community health centers, other Healthcare for the Homeless programs, especially on a national level, have been experiencing. Infrastructure, capacity, and multi-sidedness. What do I mean by that? We come out of this culture where we're small, nimble, scrappy nonprofit organizations that are suddenly not so small, not so nimble, not so scrappy, and yet don't always have the infrastructure to support and accommodate the growth that our organizations have gone through. And so many of you in this room know that since Medicaid expansion especially, we've been doing a lot of work to invest in systems and infrastructure, in our data systems, in our human resources capacity, to actually support the organizations that we've become. Growth of dental care in Maryland. I think you all know Medicaid does not pay for adult dental. It does in some states, it does not here. We had one dentist going into 2014. We've got 4 dentists today in 3 different locations. That is because we were able to leverage support that were no longer, resources that we're no longer using to subsidize basic health care, physicians and mental health therapists, for example. Outreach has been growing and is not paid for generally by Medicaid. We just separated outreach from community health worker work just this month, where we took our 2 teams and split them into 2, because so many of our outreach workers were escorting patients, clients of ours, elsewhere in the community to make sure they could follow up with specialty appointments. Incredibly needed. That's community health worker work, but the outreach work of engaging someone who's living under the Jones Falls Expressway or sleeping in an abandoned building to try to get them access to care, that needs to continue. And unfortunately, the demand of the community health worker work, getting people connected to appointments, was starting to keep our outreach workers from doing that work of engaging the most vulnerable. So we've been able to, and that's also a theme that I'm seeing around the country as well. Expansion states and non-expansion states are very different. I was just early October with my colleagues in Nashville for a meeting of the National Healthcare for the Homeless Council, which is one of the cooperative agreements that was mentioned that helps provide support to the healthcare for the homeless programs. And those of us that are in expansion states tend to be very excited about the growth we've been able to go through, and our colleagues in the 19 states that have not expanded tend to sit back in their seats and look at us askance. However, it's interesting to look at some of our colleagues in places like Texas, decidedly a non-expansion state, that nonetheless has been collaborating with funders and particularly with managed care organizations to provide housing and care to the uninsured population, because the health insurers see it as within their interest to keep people out of the local hospitals. So nonetheless, I think even in non-expansion states, there's been some really interesting collaborations that are happening. And certainly in our case, and we're seeing this happen all over the country, the notion of the role of housing in improving health is resonating very strongly. And that's happening, I think, for at least two reasons. One is that the old housing readiness paradigm in homeless services, the idea that someone had to be made, that what was wrong with that person who was experiencing homelessness was that they were broken and needed to be fixed in some way before they could be in housing. That whole paradigm has been shifting to a housing first paradigm of housing actually being the solution to homelessness. Our mayor said it just a couple of weeks ago. One of the first times a mayor in Baltimore has said that publicly. Housing is the solution to homelessness. That's really federal policy today, using a housing first approach. And the data that's happening all over the country shows that when we house vulnerable people, they tend to stay housed, their health improves, public costs go down. Anywhere between 85 and 95% of participants stay housed long term. We've been working to keep 300 people who are deemed the most vulnerable in housing, scattered sites. Some of you were at a ribbon cutting just last week at the Episcopal Housing Corporation's site in Upton, a 12-unit supportive housing site that Healthcare for the Homeless is matching clients with and providing the services for. Our first co-located collaboration. Projects around the country are doing that because the paradigm has been proven effective. But the second reason is there's a very close relationship between housing stability, residential stability, and healthcare costs, right? And we're seeing that health insurers are recognizing that all over the country. Governments are recognizing that. The state of New York has actually asked for a Medicaid waiver to fund services in housing. The federal government has said no 5 years in a row or something like that. But 5 years in a row, the state has spent state-only money to bring housing online because it's been proven so effective. We are working with the state of Maryland to implement a supportive housing waiver where the services for 100 people in Baltimore, 300 statewide, will be paid for through Medicaid. Expect to hear more about that as we move forward. And then finally, just thoughts about what you all can do to support community health centers. Find ways to collaborate and continue the successes that we have been building, and I think so many of you in this room are. I will underscore the notion of advocacy, that it is something that we can all do and that nonprofit organizations can do. I realize there are constraints on the funding side, and certainly there are limitations on the nonprofit side. But there are ways, nonetheless, that we can legally educate and advocate. And we need to show the success of our recent efforts in actually improving health. I said I would not end on a very sour note. I tend to, most of the time, when I don't get lulled into a field of depression, I tend to remember that Medicaid itself, when it was created in 1965, was an entirely contentious decision, and that most states didn't initially, that quite a few states did not initially operate Medicaid programs. Today, all of them operate traditional Medicaid programs. 19 states haven't yet expanded Medicaid, but we're seeing ballot initiatives that might result in some states. I think right now, so-called red states will have political cover to expand Medicaid, and we'll see that happening because it meets needs in communities when you get below the radar of the politics that are circulating. As we've seen, it's really hard to undo Medicaid expansion. Community health centers, strong bipartisan support historically. It's really hard to walk away from that kind of investment. CHIP, strong bipartisan support. And so I tend to remind myself that all of us have always navigated an uncertain environment. What is more uncertain than homelessness itself? This is very much what we do. I tend to resist the notion that this current environment is any more uncertain than any other environment has been, even though I think you can make a credible argument. But I think that there's so much progress that's been made, and that that progress will begin to catch on a lot more. It's happening already. It's really happening already, despite some of the negative environment that we're in. Happy to continue the conversation and answer any questions you have.
Thank you, Kevin and Alex and Jason. So we'll open it up to the group here to ask any questions, and also to our friends online to write in any questions, and John will be sure to capture that and report out. So just in thinking of everything that was presented, Kevin, I was wondering, so what are you guys doing in terms of planning? Not to end on a doom and gloom note, but I guess worst case scenario, what are you guys doing for the interim or even long-term planning, and how do you even wrap your head around what's going on and how to plan with your staff, with the community, and whatnot?
Sorry, I mentioned I was recently with a lot of my Healthcare for the Homeless colleagues, from around the country, and so a few of us got together and formed a little CEO support group, if you will, and we asked ourselves questions about what our boards are asking of us. And everyone, there were probably about 7 of us around the table, and everyone, their boards, including ours in Baltimore, had repeatedly asked us to model out the worst case scenario of what could possibly happen. And I needn't tell you that when you model out the worst case scenario of what could possibly happen, it's a pretty bleak picture. And you're cutting back on, you're making really impossible decisions and cutting back on a lot of the growth that you've achieved. And particularly within the context of the Medicaid, of the ACA repeal debate, it got really heightened there. The other thing that the 7 of us shared in common is that not a one of us would submit a budget, a worst case scenario budget in that context, right? Because it was so volatile that you could not have credibly done something. It would just be feeding into the hysteria around it. That said, all of us now are more thoughtfully and planfully modeling out what a percentage cut would look like in health center funding, what it would look like in Medicaid, what it would look like in other private support, and certainly taking those precautions, while at the same time we continue to document and demonstrate what we've been able to accomplish in the recent years.
Any questions, Elizabeth?
Just a quick follow-up to that, in terms of outreach, knowing that the outreach budgets have been cut for all the staffing that is in place to recruit to the ACA. Obviously, the numbers this morning were good, which is great, but what are you doing around that? Are you keeping people on and trying to figure out how to pay for it, or are you just having volunteers do the work, or people already in the system? What's happening around that?
So in our case, we made an educated guess back in 2012 that we were going to focus on the Medicaid population and not on the other populations eligible for subsidies through the Affordable Care Act. Other community health centers have focused equally on that population. And what we found out is that indeed we were right that the majority of those we were serving were in fact Medicaid eligible. And so we serve very, very few people who have health insurance through the exchanges. We did receive resources to increase enrollment staff for Medicaid. Just like the other community health centers, those resources have gone away. We've continued to fund it. We believe it's very important. Medicaid expansion is year-round, so we constantly provide those services. We don't target an open enrollment period. And at the same time, we've integrated the capacity to do that work in all of our front desk staff when people are coming into the clinic. So it's not just the dedicated enrollment staff anymore that can help our clients do that. So can actually do some of the work and only referring if something more complicated is needed. Yeah. So some of the easier re-enrollment work can happen right in intake, for example.
I would say that's a pretty good national snapshot too.
Exactly.
Many of the health centers have rolled into their federal grant, those resources that were there for outreach and enrollment, look at it from a year-round perspective. Health centers that were also, part of Navigator initiatives, where a lot of those, that was more state primary care associations, had Navigator grants. I think 8 or 9 of the state PCAs had those across the country. They took the hit on the resources that were providing training and TA to health centers, that were providing more reach into communities where the health centers maybe didn't have that level of support. So they were taking some of those hits. Some have been okay. They didn't have to make any reductions. But I also know some PCAs nationwide had, 80% cuts in what their Navigator grant ended up being. And so, I think the overall approach to outreach and enrollment is in the blood of the health centers overall. And so what they've done is they've done a lot of that work over the years to make it sustainable as a part of the business in all theory.
Especially when you've got that higher percentages of your patient population that are eligible, you invest in the resources that you need to be able to capture those resources.
One question over here, Mark.
Kevin, thanks for your remarks, and nice to meet folks from that. For the folks from that, from a so I think I might be the sole public here with my colleagues. We have a current RFP on the street right now, which has several strategic priorities. One of which is to help promote projects that will serve vulnerable populations regardless of their insurance status. And that's our kind of to try to be mindful of the climate that is very vulnerable. So we have an RFP on the street right now. What advice can you give us public funders that have a little bit of money that's earmarked for the safety net community in our state? What should we be thinking about as a thoughtful and strategic response at the state level to help promote our peace, state net providers, as we are awaiting these dire consequences on the federal level? And I'd like to hear folks from that.
You want to go first, Jeff?
Go right ahead.
Oh, the easy one. I think you took the first step even in class. What state agency?
It's the Maryland Community Health Research.
Okay. So
I've been around for about 12, 13 months.
Okay. So assuming it was going to be in that health world and it wasn't going to be a weird question about the finance department. Okay. But you took that first step, I think, even engaging and really putting it out there to health centers. I would say the other opportunity that's there from a state agency and a state partner opportunity is engage the health centers even prior to the RFP, engage the State Primary Care Association, also prior to the RFP, to help ask them, would this work? A lot of times we see RFPs at a federal level that would be very advantageous, to health centers. It would be a great opportunity for health centers. And then you discover, well, they're not eligible because of one weird little factor. Well, if somebody had talked to them beforehand, I think in this case where you have kind of opened it up to try to approach, I think that's taken the first real great step. From the health center viewpoint, you'll have the health centers that will look at it, is it a feasible opportunity that doesn't take them too far off track? In the current environment, they may take a pause. there might be some that take the pause because they want to stay focused on what's in front of them. There might be others who say, you know what, we might just want to bring in some other resources. If it's enough within our mission, bring in some resources, additional resources that we haven't had before. So I think you're doing, you're taking that right approach. If you're running into any challenges connecting with the PCA or any health centers, we're happy to help and make those linkages for you.
I think that, and you hinted at this a little bit, I think, in your question, access to care for undocumented populations, extremely important. And it's important, I think, for community health centers have that mandate to serve everyone who comes through their doors, but enhancing the capacity of health centers specifically to reach undocumented people in this time, I think, is really important. Dental services, I think, remain. I am just struck at the utter paucity of dental services throughout Maryland, especially for the adult population. Supportive housing, and particularly collaborations with others in the health system, like hospitals. There are great opportunities for health centers to collaborate more with hospitals that are increasingly seeing housing as within their business interests, particularly with respect to those who are residentially unstable. And then we've addressed it a little bit, but outreach and enrollment and engagement are always services that help to supplement what else is out there.
So we saw with the attempt at repeal or replace that sometimes you don't need Congress to really mess things up, so the executive branch is doing it on itself. I'm just wondering, are there champions or problematic issues within the test itself to the healthcare centers that we should be worried about?
Alex, you want to?
I think, yeah, that's been a big part of our success out there. One of our big areas of focus, and we have a really great state affairs department that works closely with our primary care associations. So something we've been really focused on is tracking the state waivers. The administration has said that they're very open to flexibility on how people might propose to extend Medicaid, including, work requirements and drug testing and a bunch of other things that we're not particularly supportive of, in addition to potential threats to the Medicaid payment system for health centers. So we've been tracking that really closely and trying to work with the administration and CMS to, highlight some of the particular things that make health centers unique, and make sure that our state associations and NAC in collaboration are working closely with state, both legislators and Medicaid directors, to promote and grow champions there, and just make sure folks really truly understand some of the things that health centers do beyond your average provider, that make their enhanced payment and the ability for Medicaid enrollment to not be quite such a hassle, and in addition to other things. So that's been a big area of focus, and then obviously tracking some of these executive orders, and the timeline, I think, is something that maybe is on our side, and our ability to provide comments and provide evidence. That's been kind of a new area of focus for our advocacy efforts, and something we're tracking with.
Yeah.
John,
And while you press that question, I'll just say, NAC has brought in health center leaders throughout the country, and PCA leaders also who have met with HRSA, the new HRSA management, have met with HHS management that I guess was flying around, and new health center management, we'll just leave it at that. And so they've been actively engaged. And the good thing is that within HRSA, the Bureau for Primary Health Care is where the health center will live. All that staff is in place. They're all career, folks. And so they are great resources. They know the program inside and out. And they are strong within the administration, for that.
So I have a question from Timothy McHugh from the Potomac Health Foundation, and he asked, can the health center folks speak to local or regions that are leading the way for increasing and diversifying funding of their health centers? Communities that tend to exceed the 13% other grants or contracts,
models or partnerships that you're seeing locally or nationally?
With 1,400 to pull from, it's kind of unique in that sense. So I think where you see, I think, Kevin provided a really good example of just from them in a 3-year period and the impact not only of what the ACA was able to do, but what a new insured population meant for the health center, and the fact that they still kept engagement with their local providers. You can see that in a lot of, I think urban environments tend to be able to diversify funding just naturally a little bit easier because of the resources that are potentially available, more partners there. But I think you see a lot of interesting rural models at times because they recognize they have to provide more and they have to do more within a community. So they're more active, I don't want to say they're more actively, but they're actively engaged in maybe other discussions around rural housing or agricultural worker health, in particular areas. They play different voices, like on the Chamber of Commerce. I've seen, I'm thinking about the Central Valley Health Network in the family health centers in the Central Valley in California, where they're actively involved in a lot of Chamber of Commerce and business level decisions. And the health center is part of the Chamber of Commerce, actually. And so that's a different way that we've seen, approach. The other thing that we're seeing is a lot of health centers are now actively starting to get their boards more engaged in fundraising. And so we're starting to see a shift in where health centers, and a new bucket of individual donors coming to the health center world more, bequeathment planning, so the more sophisticated health centers or health centers have been around longer are really getting into that, and they're starting to engage their board. And I remember one example, we did a training of how to engage your board on the ask, the fundraising ask from individual donors. And this was a Saturday morning after a long week of a conference in DC in the basement room session near the loading dock. Had 85 board members in this education session. And the one thing that they kept saying was like, we came to this because we're just waiting to be asked to help in this. And so it's such an interesting dynamic that they provided. And so we're seeing those kind of shifts. So I think where you're seeing these models are health centers that are taking some risks and starting to look at other ways and other pockets of revenues. There are health centers that have contracts with prisons, to provide inpatient services, but also as the patients exit the prisons, reentry programs. They have contracts with local businesses and factories. So it gets to be at their local levels. There's a lot of different ways that they look outside of their scope of their health center.
So I'm curious, sort of as a follow-up to that, is the healthcare for the homeless story, hugely grown, tripling the percentage of their patients who are insured. Is that typical of community health centers in states with Medicaid expansion, or is that something unique to their operation?
I think Maryland probably plays a few different factors here as just Maryland.
Well,
with the indigent program.
I think it's more typical to healthcare for the homeless program than it is to community health centers generally. So when you look at Maryland community health centers, for example, prior to the Affordable Care Act, 23% of their population, this is the statewide average, was uninsured and the rest were insured. Healthcare for the homeless was almost the opposite. And so when you look at Medicaid expansion, community health centers benefited with increases in their Medicaid population, more to the tune of 10 to 15% maybe. But healthcare for the homeless projects that were serving already that uninsured, quote unquote, single adult, the population that was not eligible for Medicaid when the program was first created, not even an optional population, they just weren't eligible. That's the population that was covered, and those clinics, largely healthcare for the homeless programs that were more exclusively serving them, are the ones that benefited in that way. I think we had a particular growth when looked relative to our national partners because of the way Maryland implemented it. But others, especially over time, have also been seeing pretty dramatic increases in their now insured populations.
Any other questions? John, online?
I've been asking them things.
Well,
I have one question that is for physical education, not healthcare, which is to say that if, if they have a smaller percentage and then they have more people that are covered under the scheme, but the options for ACA coverage are declining regardless of anything because of and rates are going up. What are the projections? What are the projected impacts of that on a traditional FQHC?
You're capturing like that subset of the subset of the subset in the question. So I think it is going to depend on the particular health center and if they're in an expansion state to begin with. You know, if they're in an expansion state, you could assume that there might be a more progressive Medicaid office that might say, if there's some ACA limitations, do they expand their Medicaid pool at all? One tight budget scenario. But I think also the health centers find the support. You know, they work with their patients. If they say that, you know, they're not going to be able to do fit within an exchange plan, they start to see where they can fit. A lot of the Medicaid managed plans too have, you know, other programs and products that they may be able to work with the clients on. And if, you know, all else fails, they fall into that federal grant pot, you know, of resources. You know, so from a health center perspective, they are looking, or they fall into the sliding fee where the patient may be able to pay, you know, a certain portion and it's being underwritten by some of that federal support. So it's really hard to focus in without like exact specific health center data there. But I think you're getting to a point that probably there are the health centers out there that are dealing with the question. But I think Kevin's point that the ACA exchanges wasn't a big boom for health centers. It was the Medicaid expansion. That was. Does that somewhat get to you? Okay.
I think we've definitely, I know I've heard individual health centers with a lot of concerns about fewer options in the marketplace, but it's always a sub-concern of larger Medicaid cuts or redesign.
Yeah. And I think where health centers are right now, you know, with the uncertainty on that 70% of the 20%, is a lot have frozen hiring already, because this hit will happen in January. You know, it wasn't a hit on October 1st. It will start happening in January, where those first grants for their year go out. So they'll start seeing it then. They've frozen hiring, they've frozen capital projects that maybe they were thinking about, they've frozen, you know, some other efforts that they were thinking about. So there has already been a hit overall. With the Medicaid uncertainty, you know, that plays into the equation some. So I think as hopefully some of these challenges become resolved with Congress, we'll start to see hiring start picking up again, you know, those kind of things come back into place.
I just wanted to underscore what we were talking about a little earlier, the insidiousness now, if you will, of attempts to erode safety nets and erode Medicaid. So it couldn't be done through outright repeal, but the things like work requirements, the vast majority of the non-disabled Medicaid population is in fact working. So we need to look at claims like that very critically. And when you have work requirements for a vulnerable and disabled population, people are going to lose coverage. It's a way to erode the basic intent of the program. I think we really have to watch out for that, as well as watching out for the erosion of other safety nets. On the community health center front, with respect to undocumented populations, community health centers are required to see anybody, and we do see anybody. I don't know what you all are seeing. We've had a couple of our members during operational site visits, which are site visits from HRSA, usually done through private contractors, to make sure that we're complying with health center core requirements. And a couple of our members that have been asked about documenting someone's citizenship. And in every case, the person said we are not, the health center CEO said we are not having that conversation and shut that conversation down. Should not be happening, and I think we need to be vigilant to watch out for any attempt to restrict health centers' ability from seeing vulnerable people, no matter who they are.
That's a great note to end on, I think. I definitely want to leave it up to you guys if you have any final comments or parting words to share. The group.
I think I would just share, things are very uncertain right now. We're seeing a lot of, as Jason said, challenges just due to the level of uncertainty, not necessarily due to a direct policy impact, but we do have a lot of support. We have a lot of supporters, and our advocates are amazing, and we're continuing to see our health centers to be a higher profile, for better or for worse. So I think we're in a good spot to be successful despite all of the different challenges, and we're just kind of keeping a vigilant eye on all that. So.
Yeah, I would echo both Alex and Kevin in their remarks, and that, what I always find fascinating about the health centers, and you probably see this as an active partner with them, is just their ability to pivot when they need to, whether it's responding to this kind of issue now or responding to sudden growth. The health center operations and those boards, they pivot so well at times, and there's bumps along the way. I'm not going to give 100%, credit. There are going to be bumps, like in any group, but a lot of my work over the last month and a half has actually been dealing with the natural disasters and the hurricanes, mainly as other duties as assigned within that. But, just the resiliencies of these organizations, and to see them both in Puerto Rico and also Texas and Florida, but to see, in Santa Rosa, California, one of the health centers lost their main building. Roof was burned right off. Flooding from the sprinklers caused it to shut down. They will be able to rebuild, but every day their other sites remained open. They were pushing patients out to the other centers right away. They were responsive. They were using social media like I have not seen a health center use it before, providing Facebook updates to both their patients and their networks. And so your investment in these centers, they're going for great organizations that are doing great work and are ahead of the curve at so many levels. They're exceeding a lot of the health outcomes data. 97% of them are using electronic health records, which is unheard of. Many of them in their third and fourth versions. And so these are dynamic organizations, and, the little engine that could over the last 53 years. And I still also think they remain the best kept secret in healthcare, as many of you know. And so any stories that you have or where you've seen those investments work, when you tell those stories, that's reminding people who make decisions, of their impact. So that storytelling is a very powerful tool that can be used, that is fully available for everybody.
Well, thank you. I think this is a great session, and I thank everyone for being here in the room, all of our friends online for participating. This is a great event, and I don't think that this conversation is going to stop today. I think all of us in the room and online will probably be contacting each other and figuring out how we can continue to work to support not only the resiliency of these community health centers, but their commitment to the people that they're serving. So if anything, I walked away, not doom and gloom, but there's, I feel really re-energized to do this work and to support the centers. So thank you. I know we'll close the webinar webcast portion of it, and we'll turn it over to Elizabeth to talk a little bit about some housekeeping steps. One last thing, the notes, slides, everything will be available on the ABAG site. Is that true?
Yeah, we'll share it.
And then I think also Care First Blue Cross Blue Shield will also have it on our website at a later date as well. So all the information that was shared will be available for